All right, you're all set whenever you're ready.
Yes. Okay. Good morning, everybody. Today I'm presenting this case report is regarding pleural dialysis as an alternative means of renal replacement therapy in 3 cats. So, as we know, acute kidney injury may require renal replacement therapy. Normally, hemodialysis and peritoneal dialysis are the traditional modality that we know. For sure, there are some limitations like the cost, the availability, the technical feasibility, and the patient size. So pleural dialysis in this case reports was considered as a novel alternative when all these other methods was not possible. So the goal of renal replacement therapy is to alter the composition of the body fluid by exposing the patient blood to a prescribed solution, such as the dialysate, across a semi-permeable membrane. In traditional hemodialysis, the membrane is commercially produced, and we have like the dialyzer. There are 4 main renal replacement therapy: the hemodialysis, the hemofiltration, the hemodial filtration, and the peritoneal dialysis. That's the one that we know. Peritoneal dialysis use a unique property of the peritoneum because the peritoneum is considered as a semi-permeable membrane. And this membrane can act as a filter. So when we do peritoneal dialysis, we instill the dialysate into the peritoneum, and this one can correct water, solute, acid-base disturbance, as well can remove substances that they are toxic, like uremic toxin and other dialysable toxin. The objective of this study, this case report, was to describe the use of pleural dialysis as a renal replacement therapy technique in 3 cats that were diagnosed with AKI, that the other technique, the other renal replacement therapy, could not be used. So we go just a quick summary about the pleural space. So as we know, the pleural space is a thin fluid-filled space between the visceral pleura, the one that is lining around the lungs, and the parietal pleura that is lining the thoracic wall and the diaphragm. The pleural space normally contains a very small amount of pleural fluid, normally is about 0.1 ml/kg in cats and dogs, but this small amount is super important because it lubricates the lung surfaces and allows smooth expansion and contraction of the lungs during the breathing. Under physiologic condition, the pressure that is inside the pleural space is a negative pressure. For sure relative to the atmospheric pressure. And that one is important to maintain the lung inflation. The pleural membrane is histologically and anatomically very similar to the peritoneal mesothelium. They are both serous membrane. They both have a single layer of mesothelial cells, and they both can function as a semi-permeable filter. So there are simple epithelial monolayer. They have a basement membrane and an interstitium with macrovasculature. That's what make it as a semi-permeable membrane. The pleura can act as a filter like the peritoneum, and that can be explained with the 3-pore theory. We have the very ultra small pore that normally contain aquaporin 1, and that's one transport water. The small pore that normally transport small molecular weight solute like urea, creatinine, glucose, and water. And then the large pore that transport more macromolecules. The hole in the pleural membrane are called stomata, or I don't know if it's correct, but I think that's how you pronounce, or small lymphocyte openings, and are located in the parietal pleura. This is the stomata, which lies inside of the chest cavity. We have a different size and different type of stomatas. So there are the ones that are on the diaphragm, and the human pleural stomata in the diaphragm pleura are often round and measure approximately 6.2 micrometers in diameter. That was from a rat, but it's very similar. In the pulmonary ligament, there are other stomatas, and this one medium ranging from 2.25 to 12.5 micrometers. And then the most important are the parietal pleural stomata that also are called lymphatic channels, and that can reach a diameter up to 12 micrometers in a human, but in dog studies show between 2 and 12 too. These pleural stomata are numerous and they are located primarily on the ventral and caudal parietal pleura, such as the area that covering the diaphragm. They are often found close to this milk spot that they are a cluster of immunocells. They're also very important because they change in size and they expand even as much as 10 times during expiration. And their main function, the anatomical function, is to facilitate the drainage of fluid, macromolecules, and cell. So this stomata, again, is very important to maintain the balance of the fluid in the pleural cavity. So we have these two main functions, the absorptive and filtering pleura. The parietal pleura is primarily involved in filtering the fluid into the pleural space and absorbing it via the stomata. The visceral pleura, on the other hand, has not a significant site on the fluid drainage. So it's very important to remember that the visceral pleura does not have any function, while the parietal pleura has this stomata. It's so important for the fluid transfer. Now, the mediastinum in dogs and cats is most incomplete and fenestrated. So there are some openings. And that's why it's important, because it influences the move of fluid and hair within the thorax. In cats, we can find some report where the mediastinum is more intact. So in some cats, the mediastinum can be more intact. And that make a more unilateral disease, or the fact that this fluid cannot move from one hemithorax to the other one. So, however, we know that the inflammation and other disease can definitely increase, can definitely close this opening, this fenestration. It can reduce the movement of fluid from one hemithorax to another one. Also, the type of effusion, so we talk about transudate or exudate, that's the rate of effusion between a transudate and exudate is different. So in this case report, they describe how they did this pleural dialysis technique. First of all, they placed this pleural catheter under sedation, so they didn't need anesthesia. The cat was, they were in right lateral recumbency. A 7 French double lumen central venous catheter was placed. It was placed midway between the ribs heads and the costochondral junction in the 7 intercostal space, and then it was directly caudally. For sure was used the modified Selding technique. They confirm the correct catheter placement by thoracic ultrasound and while instilling some dialysate. One lumen of the catheter will function as the inflow line and the other one as the outflow line.
So the dialysate was hooked up in the 1 lumen via a fluid pump. The outflow lumen was attached to a fluid line and a fluid pump. The fluid waste was collected in a sterile urine bag. A pressure transducer was connected to the outflow line to measure and maintain the negative pressure that normally is -2, -5 of the pleural space. So I could not find any picture in this article, but this is what I made by myself. So I think that's on how it was done. So that is the inflow lumen. That's, oh, I'm sorry. That's one is the pump and the dialysate. That is the outflow. And oh my gosh. And then here you can see the little pressure measurement. And then they had this 3-way stopcock that was attached to a syringe and another fluid line and a bag of plasmolyte in order to have a way to troubleshoot the catheter and to maintain the entire circuit closed and sterile. The pleural fluid recovery was between 92 and 99%. Now, I could not find, it really was not very clear how this 3-way stopcock was attached. So this is again, my little diagram that I made. So I suspect that it was attached to the inflow line in this way, but I'm not sure 100%, but that's what I will have done. So the dialysate was a 5-liter bag of plasmolyte 148 plus potassium chloride, and it was 0.05 milliequivalent kilo per hour, plus dextrose 5%. And the dose that was started with was a 10 ml kilo of dialysate that was instilled in the pleural space. The initial dwell time was 30 minutes. When we talk just dwell time in peritoneal dialysis, and in this case in pleural dialysis, the dwell time is the period where the dialysate fluid is allowed to remain in the cavity before being drained. The inflow rate was based on the patient URR. URR of 30% was used over 24 hours. This 30% equate to 0.25 liter kilos of dialysate over 24 hours. That was calculated in this way. That's what was used to minimize the develop of dialysis disequilibrium. The time of pleural dialysis for sure was depending on the patient clinical response and also on the development of complications. The most common complication in this case was a catheter malfunction. So let's start with the case summary. So this was the first cat, was a 7-year-old female spayed domestic short hair. The major clinical signs was anorexia and chronic weight loss. The diagnostic showed marked azotemia, normocytic normochromic anemia, hyperkalemia, hyperphosphatemia, and then ultrasound showed left hydronephrosis with significant left ureterodilation with single intraluminal ureterolith and also ureteritis. So the left sub on the left kidney was placed, but unfortunately the azotemia progressed despite the placement of the sub, and also the resolution of the hydronephrosis. So the sub was working. At this point, the diagnosis initially was suspected to be a diagnosis secondary to the left ureteral obstruction. And the secondary, they thought like the AKI, unfortunately, was an unknown region. So at this point, they decide to perform the peritoneal dialysis for 4 days.
As you can see here from A to B, that is the 4 days period, we have a kind of a significant decrement of the creatinine from 10 to 7.9, and then we can see that this creatinine like reach a plateau. In fact, the outcome was the azotemia show improvement initially after reach this plateau. 2 weeks was rechecked. 2 weeks after the peritoneal, the pleural dialysis was rechecked the azotemia and still static at that value. They say that ideally another 2-3 days of dialysis was possible recommended, and then they discharge the cat with the traditional therapy for chronic kidney disease. The second case was a cat, 3 years, female, spayed, snowshoes cat. The clinical signs, main clinical signs was vomiting, anorexia, lethargy, pain on abdominal palpation. The ultrasound was remarkable. The urine culture was positive for group G strep, as a very severe progressive azotemia, and at the end developed oliguria. So the diagnosis was AKI oliguric secondary to pyelonephritis. Pleural dialysis was performed for 24 hours. Here we can see the 24 hours time from A to B, and we can see that we have a significant decrement of the creatinine. So the outcome was that azotemia resolved. The renal values remain stable also after the peritoneal dialysis, and the patient was discharged with the Clavomox for UTI and possible pyelonephritis. The cat number 3, so the third case, was a 6-year male, domestic short hair. The main clinical signs was abdominal pain with a suspected mid-abdominal mass. The diagnostic shows severe azotemia. The ultrasound show moderate left hydronephrosis with mild proximal hydroureter. They did the bilateral renal aspirate, fine needle aspiration, and they didn't find any abnormality. So they want to stabilize the patient before considering a placement of a sub. So they decide to do a pleural dialysis and they performed in 24 hours. In 24 hours, they didn't see any improvement in the azotemia. And unfortunately, they decide to euthanize the cat. But here you can see that the creatinine in these 24 hours didn't improve, and it was a kind of significant elevated. So after the euthanasia, they did a necropsy. And this was helpful because first of all, they had a diagnosis, but second, they also found that they were not changing in the thoracic cavity. So that's one can, kind of tell us that there are no complications with the pleural dialysis. What they found was that the urolith was identified in the left ureter, so was causing this mild to moderate obstruction. In the right kidney was a neutrophilic interstitial nephritis. In the left kidney were marked tubular hypertrophy and hyperplasia. And then they also in the right and the left kidney, but more in the left kidney, they found moderate to marked numbers of crystal inside the tubules. So why they decide to do pleural dialysis instead of the peritoneal dialysis or the other hemodialysis? The case 1, the dialysis catheter placement was attempted twice. It was unsuccessful. The case 2, the hemodialysis was unavailable due to machine limitation. And then the cat was recently undergone abdominal surgery, so the sub placement. The third, the cat has an intra-abdominal disease. and then left ureteral obstruction and pyelonephritis. So they want to stabilize before the subplacement. All three cats, as the results, all three cats tolerate the pleural dialysis very well. The complications were minimal, and the most complication was a catheter occlusion. So they saw that the two of the cat has improved azotemia, and they also have stabilization of the electrolytes. So pleural dialysis can provide temporary renal support when other renal replacement therapy are not available or not feasible. In fact, intra-abdominal pathology can preclude the peritoneal dialysis. Dialytic machines are not always available in all hospitals. The animal is hemodynamically unstable. And also, as we know, the blood resources are limited when we have this small size patient that need a priming for the hemodialysis machine. So the advantage of the possible advantage of this pleural dialysis is, first of all, very simple, lower cost, is feasible in small patients, and based on these 3 case report, has limited complication. The limitation that in kind of has not too much clearance in 2 cases, 2 of the 2 cases. The catheter was obstructed multiple times and also is not validated as a procedure. The 3 mechanisms that we know peritoneal dialysis use, but can we use also can they kind of be transporting the pleural dialysis too, is diffusion, osmosis or ultrafiltration, and convection. So let's go a little bit as a summary. So diffusion in the peritoneal dialysis and pleural dialysis is the most important mechanism. So these solutes move from an area at high concentration, that is the blood, to an area of lower concentration, that is the dialysate solution, across this semi-permeable membrane that is, in case of the pleural peritoneal, is the membrane that we found anatomically. The rate of diffusion depends for sure of the solute characteristic. First of all, the concentration gradient, the molecular weight, and the surface area. And that goes with the first law, the Fick's first law of diffusion, where the rate of diffusion is depending of the concentration gradient. So the difference between across the membrane, so more is concentrated and more fast goes through. The surface area available, so the larger is the surface area and more can go through diffusion. And the membrane permeability, that in case of the dialyzer is a constant diffusion coefficient. The second mechanism is ultrafiltration, or in case it's better probably than ultrafiltration is osmosis in this pleura and the peritoneal dialysis, because this is driven by an osmotic gradient. So for example, in the dialysate, we add this glucose, or the new one is the icodextrin, that are rich solution that create this osmotic gradient, so that the water can move from a high osmosis to a lower. The other one, very minimal in this case, is convection. So this is the movement of solute that along with the water. So we call this one solvent drag. So when we have this osmotic ultrafiltration across the peritoneal or pleural membrane, that can also increase not just the water, but also the transport the drag of these solvents. And so go complementing the diffusion, and the can in this case is very minimal, but can increase the overall clearance. Also, when we talk about solutes and how they cross this semi-permeable membrane, we have to consider definitely the molecular weight. So small molecule weight that they cross easier. The volume of distribution, the solute volume of distribution, and also the protein binding to this solute. And also, not only the solute, but then we have to consider the characteristic of the semi-permeable membrane. So the thickness, that's why the pleura and the peritoneum are very good because are monolayer. The effective surface area, so how much is extended this membrane. And then also the number, the size, and the shape of the pores that they are these diffusion channels, so where these solutes of water go through. So as a kind of a summary, we say that diffusion can allow water, uremic tox, electrolytes, and all small molecules to equilibrate across the peritoneum or pleura membrane. For sure, the small molecules, like I said, diffuse faster than larger molecules. The diffusion is the main mechanism for peritoneal and pleura dialysis. Dialysate can be formulated based on the patient needs. And there are a very limited number in the pleura and the peritoneum that have large pores, so very small number of large pores. That's when it's important because it prevents the movement of macromolecule like protein. So this peritoneal dialysis can be, viable salvage therapy in cats with AKI when the conventional renal replacement therapy is not available or peritoneal dialysis cannot be recommended, is not recommended. When a peritoneal dialysis is not recommended, first of all, when the cavity of the peritoneum cannot accommodate the dialysate safely, like for example, if there is an infection, sepsis, surgery, if there are adhesions or tumors. Or when we have a systemic risk like respiratory compromise, severe hypoproteinemia, coagulopathy. So all these cases, peritoneal dialysis is not recommended. So the conclusion is that this is the first report of pleural dialysis in cats. These cases demonstrate that it can be feasible and can have a clinical application. So can be used in critical care and also between nephrology specialists. But definitely they need more study and need more protocol, also safety, efficacy, etc. So I was very short, but this is all. Any question?
Thanks, Simona. That was a great overview of not only the mechanisms of peritoneal and pleural dialysis, but a nice review of the paper.
Yeah, did you understand where was the, I couldn't understand where they put the three-way. That's how I thought it was, but it was not clear. But
yeah, I think I wasn't sure if they had, yeah, that was my, where you put it is where I thought as well too. It
okay.
clear.
Yeah. Mm-hmm.
There was a lot of information that wasn't clear in this.
You're right. I agree with that. Yeah. Mm-hmm.
Yeah, I mean, I'm happy to lead off some comments here.
I was going to say, when Simona asked me if I understood, it's like, I'm going to have to go down and play with 2 fluid pumps and see. I can't figure out exactly where they're doing it and putting it either.
Yeah, there's certainly details that would be nice. If they would have shown their circuit, that could have been nice. Like you did a really nice job of making the figure, but we have to guess because they didn't explain
You're right. Mm-hmm.
Yeah, I actually am have a lot of problems with this case series. And I actually, I think it's a little dangerous that it's published because only one of these three cats, I think, should have been a candidate for pleural dialysis. It seems like they did it in the one cat that had the recent sub surgery. And as you said, recent abdominal surgery is a contraindication to doing peritoneal dialysis because you're going to have leakage to the laparotomy site. It can impair wound healing. You might have a greater risk of that surgery site to become infected. So you could make an argument that maybe in that cat, that was the only option. But the other two cats, they didn't have contraindications. Certainly pyelonephritis is not a contraindication to doing peritoneal dialysis. And it seems like they just jumped to doing pleural dialysis rather than considering PD, which to me just seems like we did pleural dialysis once. We thought it was really cool. Now that's what we're going to start doing in everybody because it is not at all standard of care. And it wasn't indicated in 2 out of the 3 cats. So I don't, I'm not saying dialysis was, but pleural dialysis was not indicated in 2 out of the 3.
Yeah, no, I agree with you. I also thought about that.
And then I find it frustrating because they didn't give us any information on the doses of dialysis that was actually we don't actually even have weights on the 3 cats. So, I mean, there's a lot of information that wasn't provided. So I actually did some of the math to try to figure out, assuming these are 5-kilo cats, because they tell us that the dose of pleural dialysate at least is like a 1/4 liter per kg per day to start with. So if they're 5-kilo cats, then that's going to be a 1.25 liters per day that they're going to have as pleural effusion, pleural dialysate. And we know that if that's the case, then they can't have a clearance that's going to be higher than the flow rate. So the one cat that had the dramatic improvement, I think that's this cat number 2. Its azotemia went from a BUN greater than 200 to 20 in 24 hours. That's like a KT over V of 2.3 in 24 hours. And that there's not a chance that that's from the pleural dialysis alone. It's way too high of a dose. It's because whatever underlying disease that was there, probably a ureteral obstruction, unobstructed itself. So there's no way that the pleural dialysis contributed to that much clearance in that patient. Unless maybe the size is different. But again, they didn't provide any weights whatsoever. The first cat only had a KT over V of 0.88. And if we look at that over the course of 4 days that the pleural dialysis was delivered, that would only be a clearance of 0.46 mils a minute, which is hardly anything. I would argue that's almost negligible clearance. And again, that's just me doing math, assuming that this cat is 5 kilos and they're using the same dose over 4 days, which they just don't describe. So clearance of a 0.5 mil a minute is exceptionally low. Now, it might have contributed something, but I would not consider that an effective therapy if that was the dose of dialysis that I was delivering. Only the third cat might have had an actual dose of dialysis that was reasonable. That one I calculated it had a KT over V of probably 0.85 over 24 hours, which gave a clearance of about 1.77 mils a minute, which is probably the most accurate of all the 3. But they don't give us that information. And so I'm really frustrated because this paper just kind of describes the technique and says it could be done. Sure, it needs to be modified, but they have more data. They could have given us a lot more information, and it wasn't done. And my fear is that people will see this case report and will jump to doing pleural dialysis in patients. And I don't think that that is safe, should be standard of care. It should be really reserved for patients that hemo is not an option because you either don't have a machine, can't get a catheter in, or peritoneal dialysis is contraindicated because of the contraindications that you showed, then perhaps pleural dialysis should be the case. But none of that is actually mentioned as the limitations, or the authors don't suggest with any caution about its use. And so I worry about people seeing this and be like, oh yeah, let's just try it this way. This seems
Yeah.
really cool. Nothing bad could happen. And I don't know. If I was the reviewer, I would have rejected this article. I would not have had it published in its current form for sure.
Yeah, no, I agree with you. Yeah.
But those are just my thoughts. I'm wondering what other people might be feeling about the article as well.
Katie, thanks for that. I am very ignorant, and with dialysis, I'm practically a urologist with what I do, and so I've challenged myself to read and participate in these to help myself get more intelligent. And I just had a hard time conceptually, and thank you for doing the math, because I think the third case that you described makes sense conceptually to me, that it just seems like it would be incredibly inefficient. And if you think about, like, they were trying to maintain a -2 to -5 millimeter mercury pressure, and the amount of, you think about what normal pleura is, and I believe, Simona, you described that in the paper, and I think it was like zero 0.1 mils or something per kilo or something like that.
Mhm. Yeah.
Right. And so you think about what the normal physiology is of the pleura, and it just seems like in order to be effective, I can't imagine. And like, I agree with you, that first cat, I was like, well, something happened with that first cat. It had an AKI and it improved. It just seems like you couldn't possibly have enough clearance with just the pure volumes that you could use. But maybe I'm totally wrong. It just seemed like conceptually that just seemed really challenging in a cat.
No, I think you're absolutely spot on, because if you compare to what we do with peritoneal dialysis, and certainly um, Mary can comment on this too, since she probably has more experience than most of us here. But the whole point is you have to let the fluid dwell. You need to let the fluid dwell so that it has time, so that solutes can equilibrate across the semi-permeable peritoneal membrane. And then once you have your dialysate in the abdomen with all those solutes that have accumulated, then you drain it out, and you're going to then get your clearance of those solutes, and then you refresh with new dialysate in the abdomen. If you're doing a constant rinse where it's being put in and drawn out so that you can maintain that you're not getting an accumulation in the pleural space, that significantly reduces the contact time for solute equilibration. And with peritoneal dialysis, you actually start with shorter dwell times so that you don't have complete equilibration across the peritoneal membrane. And then as you're increasing your dose of PD, you can allow the volume to increase so you have more surface area that's recruited, and a longer dwell time so that you can ensure greater equilibrium across the peritoneal membrane before you remove the fluid. So the smaller the volume, the shorter the contact time before it's removed, allows for minimal opportunities for solutes to be able to move. And especially those that are going to be larger, that have slower kinetics across the 3-pore model that Simona showed really nicely. So I agree. It doesn't really afford a high rate of clearance, which is certainly needed for these patients that are that severe. And you wouldn't want to then pinch off the catheter and allow 100 mils to start dwelling in the cat's chest, because it could lead to respiratory compromise.
Mhm.
So it seems like it has significant limitations in terms of how efficient it could be, to the point where, is it efficient at all? Or were these changes that we were seeing reflective of the underlying change of kidney function that was happening in the patient? I think that first cat, after it was treated for 4 days, this was after it had the sub placed, the azotemia didn't worsen after pleural dialysis was discontinued. Well, if it's not going to worsen, then to me, that means that the kidney endogenous creatinine clearance improved. Otherwise, as soon as you stop pleural dialysis, just like if you stop PD or hemodialysis, the values are going to get better unless you have improvement in residual kidney clearance. So who's to say that the changes that we're seeing during those 4 days aren't due to just the return of kidney function on its own? And we just don't know that at all from the data that's here in this case series.
I couldn't have said it better, JT.
Yeah.
I'm happy
Um,
that you agree with me, Mary.
Yeah, I agree with everything you said. I couldn't have done it better. One of the reasons I actually suggested this one to Simona, because I was hoping it would kind of bring up this kind of discussion. I'm surprised it got through reviewers as well. I kind of wonder if the reviewers were thinking, ignoring the details to, oh, this is a unique concept for therapy, and focused in on that, and that's why it slid through the review process. I just don't know. There is one report in horses. It's also a single case report of doing a continuous form of peritoneal dialysis. They, hung the bag of, they had 2 catheters in, they hung their 5-liter bag and continuously let it flow through and then drain out through another catheter. But and that's how it was. The title, I think, was, continuous flow through peritoneal dialysis. But if you read through it, they actually did a typical PD session for the first, I can't remember the number of days, but a number of days until the values started coming down. And then I think they get tired of manipulating and doing, dwell times in this horse and having to keep everything neat and clean, and then just added in the continuous flow for a few more days until the horse seemed to recover enough that they just, pulled the catheters and sent it home. But that's, there have been a number of reports of actually pleural or respiratory compromise in cases of peritoneal dialysis, where the volume of the exchange actually was compromising, and the patient actually developed pleural effusion secondary to excessive volumes within the abdominal exchanges. But it did get us some discussion, though. I loved that part of it, that we could all talk about these things, because, we so very rarely have to employ peritoneal dialysis, but I think we get kind of too comfortable with more and more centers available. But there are parts of the world, and in human medicine, there are parts of the world that just don't have easy access to any extracorporeal therapies, and they use, peritoneal dialysis as intracorporeal therapy. And there's, in the human medicine, there actually over the last few years has been a rise in the number of people going on to chronic ambulatory PD, just because it gives them a little bit more latitude of life and being able to do things, and not having to have long downtimes where you're sitting in a dialysis center hooked up to a machine. But Simona, nice job.
Thank you. I didn't know if I was allowed to put all these points that I didn't agree with, but I'm glad that the JD and you
Well,
talked about. So
I mean, that's what we should be doing. You should always, question the literature and look at the data yourself and interpret it and see if it holds up to what we think is a correct way of interpreting data, and whether they provide all of the data that is needed.
yeah.
Excuse me.
Are you sick?
I have a little laryngitis.
Yeah. Well, thank you guys. I appreciate it.
Thanks, Mona. I think you did a great job.
Thank you,
Glad you
guys.
looked at it and hopefully generated a lot of thought-provoking aspects based upon the manuscript and what's done in the future with it. So appreciate all of it.
You
Thank
should
you so much.
send your little diagram and make a letter to the editor with your concerns and ask that they improve their manuscript. And here's a suggestion.
Yeah, that was a try. I tried to do it. Thank you again. Have a wonderful day.
Thanks, everybody.
Everybody. See ya.
Bye-bye.